Welcome everybody. Hi, it's Dr. Arturo Taca, and on behalf of Elm Freedom Tree Network, I'm here to give you another presentation on genetics and psychiatry. So today, this is going to be our agenda. We're going to talk about primarily depression and the burden of depression and why it's important diagnosing depression and its different forms. Later on, we're going to talk about a very influential study that was done by the government, actually. It's called the STAR-D trial, and its efficacy of the current choices of antidepressants out there. And then later on, we're going to talk about genetics. Why do genetics? And before that, we're going to talk about just the basic genetic 101. So here we go. Major depressive disorder is a common and recurrent condition that can be very disabling. Some people think that depression is kind of all made up and it's a lack of willpower, a lack of moral attitudes. People have personalities, and but it's a real condition that affects the brain. And when you have dysfunction of the brain, it can lead to a lot of disability and poor outcome at work and high costs of burden to society. The lifetime prevalence is between 10 to 15%, when women are affected more than men. Over 2/3 of people with major depression have recurrences, which means not only will they have a bad episode, 2/3 of those people with bad episodes may have further episodes in life. Depressed adults have twice the annual health care cost as non-depressed people. Now, if you look at this slide and look at all the causes worldwide for mental illness and disability, you have the regular unipolar depression as number one, 10%, almost 11% of the total of the world's disability because of major depression. And then if you keep on going down, you have alcohol use disorder, bipolar disorder, schizophrenia, and OCD. Now, collectively, that's 1, 2, 3, 4, 5 out of the top 10 worldwide disabilities handled by psychiatrists. Now, a lot of people think that psychiatrists are not real doctors. However, look at this list. Most of our patients are disabled at a higher rate than any other specialty, okay? So it's important to diagnose major depressive disorder, and the tool that we have is the DSM. The DSM is a big book that we use in psychiatry that describes all the conditions that we have in psychiatry. Unfortunately, we don't have a blood test or a scan or an imaging tool that can look at the brain. Not like other specialties. You can get a blood test or other specific tests that can diagnose a condition. We don't have it. All we have are descriptions. So the DSM, and we're at version 5, describes 9 symptoms. And we're required to, if you have 5 or more symptoms present during the same 2-week period and causing significant distress or impairment, you could qualify for a diagnosis of major depressive disorder. So some of the symptoms must include depressed mood most of the day or nearly every day. That's called dysphoria. Loss of interest, loss of pleasure, loss of activities most of the day or nearly every day. And when it becomes every day, we call it anhedonia. Now, depression could be a lot of things. It's not only sadness. It could be a lot of things. It could be poor concentration. It could be low energy. So it is sometimes difficult to really figure out, is this regular major depressive disorder, or is this something that's related to a medical condition that is presenting with vegetative symptoms of depression? So This study, called the STAR-D study, was done, it was started in 1999. It lasted 7 years, and it was funded by the National Institute of Mental Health. UT Southwestern in Dallas was a big coordinating center for this study. And the data coordinating center was actually here in Pittsburgh, Pennsylvania. The author was Dr. John Rush from Southwestern Medical Center in Dallas. And STAR-D stood for the Sequence Treatment Alternatives to Relieve Depression Trial. So it was the largest clinical trial of depression ever. It was conducted in primary care as well as psychiatric settings. Few exclusion criteria were implemented, making it a real-world setting, which means that if patients came in, you were treated. There were no placebo arms. There were a large number of minority patients, and everybody had the opportunity to do cognitive behavioral therapy, which in itself is a good therapy for depression. Patients were combined, randomized, and the outcome was remission rather than response. So we were looking for a complete remission of symptoms. So what we saw was collectively, it wasn't very effective. Antidepressants only worked a minority of times. So how it was designed was there was 4 steps. The first step was you started on an SSRI, citalopram. And then if you didn't get remission, you'd be entered to step 2, and then step 3, and step 4. And this slide, if you look at it, it suggests that the first step, you had 37% remission. Now those people who didn't remit were placed in step 2. They were offered different antidepressants from other classes, SNRIs, and then used perhaps other strategies, including Buspar and tricyclic antidepressants. What we wanted to do here was present a naturalistic, real-world kind of condition, which was done in the community. And what we saw was as you got as you went along through each step, as you failed, it got harder to treat. So collectively, antidepressants only worked about 30% of the time. Now, that's very controversial because psychiatrists won't tell you that. So in reality, what psychiatrists deal with are people who are started on an antidepressant because they qualify for a diagnosis. We offer an antidepressant, it works sometimes, most of the time it doesn't work. We switch them to another med from a different class, sometimes it works, most of the time it doesn't work. Then we add another medication from a different class, sometimes we might combine medications from 2 different classes. So we see this, this phenomena that I'd like to call it a misadventure, like a therapeutic misadventure. And psychiatrists have kind of accepted that. But the low batting average is something we lived with. Now, if you compare that with other specialties, like, for example, if you had an infection, you got an antibiotic, and most of the time, it would work, right? Maybe you'd have to add another one, but most of the time, that specific treatment would work. But in psychiatry, it's different. We kind of throw things at we throw darts at the wall and see which one sticks. And we've kind of gotten used to that. But many of us, including myself, feel a little desperate because, you know, it's not a way to drag, you know, people through the mud. And other people are starting to say, hey, what's really the utility of these antidepressants? This next slide showed that antidepressants, and they looked at people who, after 2 years of follow-up, people who were started antidepressants, researchers found that there was no statistical difference in health-related quality of life scores in those who took antidepressants compared with those who did not. So at the end, they concluded there was no link between antidepressants and improved quality of life. So people on antidepressants started feeling miserable, and many of them continue to feel miserable. The issue is, it's hard to get off antidepressants because of discontinuation syndrome. So a lot of people are kind of stuck. So what do we do in psychiatry? We're looking for other options. Here's another example of how antidepressants can be very, very controversial, even within our specialty, the Psychiatric Times. Serotonin or not, antidepressants work. Well, we're not sure, but it would be embarrassing if the psychiatric industry would admit that all this time that we were doing the wrong thing. But you look on Newsweek, hooked on hype. So, it's very it's confusing what the normal run-of-the-mill person coming in. Should I take medications or shouldn't I? So this is the psychiatric misadventure I'm talking about. So this cartoon kind of addresses that. Doctor, the medicine makes me feel worse, not better. And the doctor says, let's increase the dose. So this is a famous cartoon, Lucy, Psychiatric Help 5 cents, but the psychiatrists need help. So we are looking for other tools to improve outcome in specifically psychiatry because of this very, very poor batting average we have. So why do genetic testing in psychiatry? Why do it? Is there one drug that fits all? Obviously not. Genetic testing, it can provide personalized, specific to the patient, personalized medicine. Provider-centric care to the versus patient-centric care. Medicines can be given based on genotype. Medicines are based how the body metabolizes drugs. Some of the information in genetic testing can predict adverse drug reactions. It can avoid trial and error of overprescribing. And it can potentially be more effective and less expensive when you get the right drug, the right dose, the first time. So there's a thing called pharmacogenomics or PGX testing. Pharmacogenomics can play an important role in identifying responders and non-responders to medications, avoiding adverse events and optimizing drug dose. And this is lifted straight from the FDA. So how do you collect this? It's a very simple procedure. There's a mouth swab. You just do it once. You don't have to do it more than once. It's a one and done thing because your genes do not change. And it gives you more information leading to better outcomes. Now, my disclaimer is that I am not a geneticist. Clinical geneticists have medical degrees such as MD or DO or equivalent degrees and have completed at least one residency year in specific training in genetics or genomics, okay? I am not a geneticist, but there are geneticists in communities that are experts in this field. Just a little background on the evolution of genetics. So these two scientists, Watson and Crick, discovered the structure of DNA, which was described as a helix back in 1953. So in 1953, Watson and Crick described DNA's double helix. Investigators discovered a genetic link to hemolytic reactions to primaquine in 1956. So this was the start of genetic medicine. In 1957, Matulsky proposed that inheritance might explain many individual differences in the efficacy of drugs and in the occurrence of adverse drug reactions. So now we're kind of describing, hey, there is a connection between our drugs and how what our genes do to those drugs. And in 1959, the term pharmacogenetics was coined. In 1990, the Human Genome Project was started. And I remember in 1990 when it started, I remember being told, we will never see the outcome of this study because it's going to take, 100 or 200 years. Well, they finished the Genome Project in 2003, which was 13 years later. So what are genes? Genes are composed of 50 trillion cells. Inside cells are the nucleus. 99.9% of genes are in the nucleus. There's a total of 30,000 genes, and genes make up DNA. All genes, if you put them all together, is about 6 feet long and fits all in one nucleus in a double coiled helix. Genes are recipes to make proteins. Genes tell a cell how to function, and that is called transcription. Further organized into chromosomes that consist of 23 pairs. So this is the structure of the DNA. If you look at the middle of a cell, that is the nucleus, and that's where all the good stuff is. That's where the chromosomes, the DNA, the instructions of who you are. And to activate the genes, to make them work, is called transcription and translation. So there's a process that translates all those instructions to do whatever it's programmed to do. So there may be instructions in the DNA that says, Jimmy's going to have blue eyes. Well, that has to be processed, that has to be activated. And that's a process of transcription and translation. So what are SNPs? SNPs are single nucleotide polymorphisms, and that accounts to the differences in appearance or how we respond to drugs with no action. We get one set from mom and one set from dad. Females have 2 X's, males have 1 X and 1 Y. The genotype is the DNA recipe of you, and the phenotype is the physical observable differences that we see in each one of us. So again, in 1993, it took 13 years and $3 billion to map the whole genome. Today, it takes about 1 week and about $2,000 to map the whole genome. However, if you spend $99, you can get a lot of information from a place called 23andMe and things like that. As costs keep dropping, more people's medical records will include genetic information. So why map these genes? Why is it important to understand what genes do in the body? If you look at 9 of the 10 leading causes of deaths from the CDC, they all have genetic components. That's why it's important to look at genes. What are pharmacogenomics versus pharmacogenetics? Both sometimes are interchangeably used to describe the study of how genes affect a person's response to drugs and the metabolic pathway in the liver. So current applications of genetic testing, there's prenatal testing, newborn screening called the PKU, there's genotyping, and then there's predictive testing in cancer and infectious disease. These are current applications of genetic testing in medicine. What we are starting to do is called pharmacogenetics and pharmacogenomics. And so some of these are listed here. What are the causes of variations of response? Gender, age, mass, body mass index, toxins, and presence of other medications and genetic factors all cause variation in response to drugs. So you can see how if you take a population, there may be a certain population that is good, and there's some that are toxic and beneficial. So not everybody will respond the same to the same drug. So this is a illustration of major drugs that are ineffective for many and sometimes harmful to some. Anti-hypertension drugs like ACE inhibitors are ineffective to up to 30% of the people. Heart failure drugs like beta blockers are ineffective 25%. Antidepressants are ineffective 20 to 50%. And cholesterol drugs and asthma drugs have an ineffective response to up to 70% of people. So you see, these medicines don't work for everybody. Is this problem real? Well, there's 2 million people that get admitted due to medication-related problems, leading to 100,000 deaths a year. Only 58% of pain patients get pain relief. So there is a variety of a variability of people who respond, and sometimes they can end up in the hospital. So quickly, we're going to talk about pharmacokinetics versus pharmacodynamics. Pharmacokinetics is what the body does to the drug, and the pharmacodynamics is what the drug does to the body. The cytochrome P450 system refers to the system in the liver that describes a metabolism of that particular drug, and it can be described as a poor metabolizer to an ultra-rapid metabolizer. An ultra-rapid metabolizer describes that the levels may be too low because it's getting metabolized too much, which may lead to ineffective effect. And a poor metabolizer is the opposite. Drugs last longer, you can have severe side effects, you can be involved with accidental overdose and death. So here are some of the signals that I use in general psychiatry and in my addiction practice. So there is a signal called MTHFR deficiency, which refers to how a body metabolizes folic acid, which is a B vitamin. Now, if you have a deficiency here, you don't get the L-methylfolate, which is the activated form of folic acid. You don't have a complete, you don't have an efficient way to synthesize neurotransmitters, and it may be associated with mood disorder, anxiety, and depression. So when we identify MTHFR deficiency and people are depressed, we supplement with L-methylfolate before we start going down the antidepressant or mood stabilizer pathway. OPRM1, which stands for opiate receptor mu-1, predicts response to naltrexone for alcohol dependence. GRIC1 predicts the anti-craving effect of topiramate for alcohol use disorder. SLC6A4 predicts the SSRI effect and ondansetron anti-craving effect for alcohol use disorder. COMT describes how one metabolizes dopamine. If you have an activated or a highly active COMT, one could be described as having a dopamine deficiency, which can lead the brain to be looking or hunting for dopamine in the environment. DRD2 refers to the dopamine receptor subtype 2 that refers to reward deficiency syndrome, which means that if you have a dysfunction of this receptor, a brain is again hunting for dopamine, which can lead to impulsive behaviors. These next two predict an anti-epileptic or mood stabilizer function in some people. Some people respond better to these anti-epileptics versus antidepressants or antipsychotics because of hyperactive signaling in the brain. And these anti-epileptics modulate the communication in the brain, which could lead to a mood stabilizing effect. And lastly, the human leukocyte antigen B predicts the skin reactions from certain anti-epileptics. So as you can see, all this information is important for a psychiatrist or somebody who is treating somebody with depression and a substance use disorder. You can pick the right medicine for the mood disorder, and you can predict which medicine may be a better anti-craving strategy for some disorders. So experts acknowledge the potential for gene testing making a significant difference in the future. I'm quoting a psychiatrist, a well-known psychiatrist, Charles Nemiroff. Although pharmacogenetic testing will almost undoubtedly prove critical in customizing treatment in psychiatry, testing to guide the selection of psychiatric medications, quote, may not yet have reached the threshold of clinical utility. So he said, I have no doubt that in the future, lab tests will be helpful in identifying who is at risk for major psychiatric disorders and individualizing treatment for that given patient. But he cautioned that the bottom line is that we don't feel we are there yet. The APA, the American Psychiatric Association Task Force for Novel Biomarkers and Treatments, had a statement looking at claims of 4 major commercial companies offering genetic testing to improve medication choices and reduce trial and error. They concluded that there was not sufficient information to support the widespread use of pharmacogenetic testing in clinical practice. Authors of the editorial in JAMA Psychiatry in May of 2018 came to a similar conclusion of insufficient evidence to support widespread use of genetic testing to make depression medication decisions. So the conclusion is that mental illness contributes to worldwide disability. Mental illnesses are highly genetic. Stigma around mental illnesses has improved. The use of antidepressants remains very controversial. Efficacy of antidepressants is questionable. Overuse of psychiatric medications causing therapeutic misadventures are common. And we are in the early stages of genetics in psychiatry, but can be helpful. So I hope you enjoyed today's lecture on depression and genetics, and I'll see you at the next meeting.